Hello and welcome to Cancer Close-Up, the podcast from WVU Cancer Institute in Morgantown, West Virginia. I'm Nida Bham, a thoracic surgeon here at WVU, and we will be talking about lung cancer, everything about it, the myths, facts, and I'm here with Dr. Almubarak. I'll let him introduce himself.
Thank you, Nida. I'm Mohammed Almubarak. I go by Dr. Mo. I'm a medical oncologist. I specialize in treating patients specifically with lung cancer, and I'm happy to be here today as well.
All right, perfect. So, Dr. Almubarak, we'll get right into it. Let's discuss why are we here. We're here on a Wednesday morning. We took time out to do this podcast for our viewers out there, and I think let's do a little bit of a shallow dive on why are we talking about lung cancer here today.
Absolutely. So, lung cancer as a cancer is one of the more common cancers. It's definitely fairly common, both men and women. By incidence, by how many people actually get it every year, it's the second to breast cancer in women and second to prostate cancer in men. But when it comes to deaths from cancer, lung cancer is the leading cause of death in both men and women. Those sounds like a pretty gloomy picture, but the reality is actually we've made a lot of advances in the treatment of lung cancer, both in detecting cancer as well as treating it. And I think it's time to change how we look at it. I want to make sure that people out there know that we have many options treating the cancer, keeping people alive with it for a long time, a lot of times curing the cancer as well.
I think that's absolutely right, Dr. Almubarak. You touched on some great points. Lung cancer, it's oftentimes thought about as this scary diagnosis. And yes, it's true that it is the number one cancer-related killer in the U.S. In fact, more than breast cancer, cervical cancer, colorectal cancer combined, like you said. But it's not all doom and gloom. In fact, now here in the U.S., we have more survivors than ever before, which is what makes our job so exciting. So let's, Dr. Almubarak, I think let's perhaps talk about some myths and facts related to lung cancer that are out there in the community that our patients ask us in clinic day to day. So, this is something that I hear very often. I don't know about you. I'm sure you do as well. Lung cancer, doc, I don't smoke. Lung cancer, I thought, was only associated with smoking. What do you have to say to that? Myth or fact?
So it's partially a myth, partially a fact. Yes, the majority of lung cancer is caused by smoking. I would say about maybe 85% of the times when somebody got lung cancer is because they were a smoker or they smoked for several years in their life. But at the same time, that we actually see more and more patients who never smoked in their life, who develop cancer. And that's due to the complex way of how our cells divide and genetic mistakes, if that makes sense. That happens. So there are certain biomarkers, certain mutations we look at. So whenever I get a patient with lung cancer, even if they're a smoker, we usually check for these mutations because the treatment is different. So if a patient, has one of those mutations, they might have an option for a pill instead of chemo or immunotherapy. So yes, majority of lung cancer is caused by smoking, but not every lung cancer caused by smoking. And a lot of times, even if somebody is a smoker, their cancer might be caused by more than one reason. I should add one more thing, that when we talk about smoking, it's not only first-hand smoking. It's not like, oh yeah, you smoked yourself. Sometimes it could be that you live with somebody who smokes, and sometimes it's a third-hand smoking. So we call it second and third-hand smoking. So, and when we're talking about smoking, we're not only talking about just cigarettes. We're talking about all other forms of tobacco as well, and more recently other ways of delivering the nicotine.
Absolutely. I think that's very important. So yes, lung cancer is not only related to smoking. Yes, majority of it is linked to smoking, but that's not the only cause. And then I think this is a good segue to talk about why do we see so, bunch of my training was in the Northeast, and then I came here and we just see a lot of lung cancers, and not just that, but just aggressive types of lung cancers here in West Virginia. So, why is that? And, again, so the smoking plays a major role in it. In fact, West Virginia, the rate of smoking is 21%, which is higher than the national average of 12 to 13%. So that certainly plays a role. But you touched upon a very other important point: secondhand smoking, third-hand smoking. And then there's other risk factors like radon, which West Virginia is above the national average for. And unfortunately, the only time that we think about radon is when we're buying a house.
Absolutely. And I've heard that this is, I don't know if it used to be $100 to get a radon testing, but it definitely is a risk factor we don't think about. And sometimes we don't think about it until after the fact. I saw a patient not too long ago who basically was not a smoker and developed lung adenocarcinoma. And, when they went back and did the testing for their house, it turned out that they have high levels of radon, and they had to do the mitigation for that as well too. Right. So absolutely, there are other risk factors. We don't want to be stuck. And we definitely don't want to get stuck with that stigma that, hey, you smoked, thus it's your fault. I think we're well beyond that.
Absolutely.
These are a lot of things. A lot of times when somebody smokes, they started smoking when they were much younger. Maybe they didn't have the full cognition of the complication or the issues that come with that later down in life. So we're definitely beyond that. We don't want to. We're not into the business of blaming people why they got cancer. We definitely don't want to look at it that way. I look at it as, everybody's trying to do the right thing, and we're at a place where hopefully we can help them.
Yeah, and like I say, your risk of lung cancer starts with you having lungs. When you have an organ, there's always a chance, no matter what, even if you've been a non-smoker, is just either it's like we talked about radon, which by the way, I ordered my test yesterday, but it's $10 to $20, $30, I think, from online retailers, so they're getting better. So not just radon, but here in West Virginia, we also have occupational exposures. So we're a coal mining state, and environmental pollutants. We know from studies and data that they also play a role.
Absolutely.
So certainly you have lungs and you have some of these risk factors, and ultimately some patients are at higher risk than others. Would you say that's right?
Absolutely. And I think this probably leads us to the next part, which is what could you do as a person to improve your odds, right? Let's say you smoked for many years and now you're thinking, hey, I might have risk for lung cancer. What could I do? Thankfully, in the last several years, we actually have a screening test now. Screening, it's called low-dose CAT scan or low-dose CT. It's done annually for 3 years to check if there's abnormality that can lead to workup. There are certain criteria that I'm going to discuss with you, and feel free to chime in anytime, basically. But the biggest one is obviously how many years you smoked. So there's a way to calculate your smoking history. So we look at how many packs you smoked a day for how many years and multiply these two numbers. For example, if somebody smoked a pack a day for 20 years, we call that 20 pack years smoking, right? So we look at that. We look at how long has it been since you quit smoking. We basically look at your age, and age is definitely a risk factor for cancer. So if you're younger, you might think, oh, hey, it's not likely that I will get lung cancer. Unfortunately, we still see earlier age cases of lung cancer, specifically somebody who started smoking when they're like young teenagers, if that makes sense. Okay, so we look at all these numbers, and if you qualify, then that is definitely a role for lung cancer screening. I'm gonna give you the chance to talk about what do we have here that's special in West Virginia that actually have hopefully improved access to lung cancer screening, and that's the Lucas program.
Yeah, absolutely. So thank you for touching on screening, Dr. Almubarak. It's important. It's here, and as of 2021. The U.S. Preventative Services Task Force Committee actually expanded their criteria for the people that are eligible to get screened. So patients, so if you're out there 50 to 80 years old, you talked about pack years, and that's very important. That's how us as clinicians, we calculate how much exposure to smoking you've had. So either 20-year pack year history and currently smoking, or quit within 15 years of smoking, you're eligible to get screened. And in fact, very recently, the U.S. court actually upheld the Affordable Care Act, where insurers are now supposed to pay for screening. So if you meet this criteria, then your insurance company is going to pay for that. And the kicker is that you don't need to stop smoking to be eligible for screening. So that's another common misconception that patients have, and a taboo in the society, that we're not going to get screening because we're actively smoking and the doctors wouldn't care for it. Absolutely no. Yes, we're here and you're eligible. So then what are the screening options? WVU, I think, has done a fabulous job through the country. So not only do we have brick and mortar sites which is a traditional site where patients can come in and, get a CAT scan if it's ordered by your primary care physician, your family doctor, or your medical oncologist or pulmonologist. But also, we are unique in the sense that the WVU state has limited access to health. And so in counties or in regions where there is no brick and mortar sites, we have what we call the Lucas program. And it is essentially I believe a 68,000 pound truck, or like a trailer that essentially roams the country roads of West Virginia, going from county to county, bringing the CT scan to the people. So we're changing how we approach medicine in WVU. This is the first of its kind. We're not now just forcing people to come to us, but we're bringing opportunities to them. So even if it's not coming to their county, you could always go to their website, you could call them, and you can see what their schedule is. You could go to a neighboring county or touch base with them to see what matches with your schedule.
Absolutely. I mean, the key thing about screening is this. Yes, you're catching cancer, but you're catching it at earlier stages, and that's tremendous. I mean, I'm old enough where, 15 years ago, most of the patients I saw were advanced stages, stage 3, stage 4, where cure was not on the table. Stage 4, a lot of times the cure was not on the table. Now we see, thanks to this screening program, we see a lot of patients with either stage 1 or stage 2, where their cancer is cured with surgery, and then we give them additional treatment depending what stage they are, and the patients are alive. And I'm starting to see these patients 5, 6, 7 years later, and these patients, they benefit from this. There's a clear-cut benefit when it comes to mortality. There's definitely a decrease in the number of deaths from lung cancer, but actually from all types of deaths, not just lung cancer, due to screening.
Right.
So it's definitely a key thing. I think it changes the perception that, hey, this is a cancer that's your fault and we're not going to do anything about it. We're more like, hey, it's there. We're going to try to catch it early.
Absolutely.
And we're going to do something about it.
Absolutely. And catching early, like you said, stage 1, stage 2, which we typically categorize as early stage, we are talking about cure. We're not just talking about treatment. Stage 3 and so forth, and again, we'll talk more about the things that you're passionate about, the molecular markers and all these testings. But even now, we're seeing much better outcomes in terms of overall survival. Back, you said 15, 20 years ago, we were talking about dismal survival rates, about 1 to 5%, 5-year overall survival rates, which are essentially the way that we clinicians say a patient is going to be with us. So those rates were poor back in the day because we didn't have all of these screening tests, these new diagnostic modalities, these new treatment strategies. But now it was a bad time to be a medical oncologist, I would say. But now it's a good time to be a thoracic surgeon and medical oncologist, because not only are we catching these people early, but even in the guarded stage 3 where there is advanced local disease, we're still talking about potential cure.
Absolutely. So let's take it one step at a time. Let's start by the earliest stages. So let's say somebody gets a screening scan. They found a nodule, right? I should say, just because there's a nodule, it doesn't mean it's cancer.
Absolutely.
Actually, the majority are not, which is okay. You find something, doesn't mean you're going to jump and do stuff. We have good team of specialists, pulmonologists, radiologists. They actually look at these carefully and say, hey, this is something we need to do workup right away, or we can wait, do our follow-up scan in 6 or 12 months. But let's say somebody gets that, abnormal nodule in their scan, they get the biopsy, they prove they have cancer, right? The next typical thing is they come to you. And how do you talk to these patients?
Yeah, so I'm going to reel back a little bit and first, so I know that we talked about screening with our people.
Yeah.
I know that we talked about, so what is, you mentioned this, and it's screening. The patients come and say, Doc, I have a spot on my lung, right?
Yeah.
So what does that spot mean?
Yeah.
You're absolutely right. It doesn't mean that it's cancer. And that's where the pulmonologists, the thoracic surgeons, you guys, we all come in together to say, is this looking sufficiently suspicious that we want to chase it? Or is it something that we can just follow along? That's our job. That's what we do for a living. In cases where it is looking suspicious, we have some modalities to offer. So diagnostics, how do we figure out if it's cancer, and if yes, then what stage of cancer it is? We have new state-of-the-art incisionless navigational platforms that we offer to the patients, where they can come in, get the biopsy done under general anesthesia, get expedited results, and essentially what that translates is less waiting time, less having to worry about getting expedited information about the type of cancer, the stage of cancer, and then hopefully to Dr. Almubarak's clinic or my clinic or our clinic together to discuss what are the treatment options. So stage 1 and 2, Dr. Almubarak.
All right, absolutely. Thank you. So I'm going to say, I'm going to emphasize the point you mentioned, which is it's usually not one of us, it's usually a team effort. So we have what we call a multidisciplinary clinic. So typically a thoracic surgeon, a medical oncologist, a radiation oncologist, a pulmonologist. You sometimes see 2 or 3 of us at the same day for convenience. So you don't have to see, different doctors, different days, multiple appointments. And that way you also usually get a consensus after seeing all us. So we meet every week, right? We have a weekly meeting where we discuss the patients, go over the treatment plan, review their pathology and radiology images. So when we talk about lung cancer, I know what we say lung cancer, but the reality is lung cancer is many diseases. There are different types of cancer. There's 2 big categories. You probably hear these terms quite often, non-small cell lung cancer and small cell. These are the 2 big groups when we talk about lung cancer. Non-small cell being the more common type, probably 85% of the times it's the non-small cell, and small cell is the 15%. So under the non-small cell, there are different types of cancer. We talk about adenocarcinoma, we talk about squamous cell lung cancer, we talk about large cell. All of these names, I tell my patients, hey, it's good to know, but I don't want it to get obsessed, I need to remember this name. A lot of times it is available in their records, obviously. But the treatment is different depending on the type of the cancer as well as the stage, right?
Correct.
So the number 1 step is establish that this is indeed a cancer. We do biopsy. We don't say maybe, we say for sure if it's cancer or not. After we do the biopsy, we want to do a staging workup, right? And that involves your specialties, like whether it's, like you mentioned, the navigational bronchoscopy or mediastinoscopy. There's certain procedures because the stage makes a big difference.
Absolutely.
So for the earlier stages, stage 1 and stage 2, that's typically mostly your specialty than mine, I'm going to say. A lot of times, the patients see you, right? And hopefully before they get to you, sometimes they'll have pulmonary function tests to assess whether their lungs are good enough for surgery. Like if they're able to withstand the type of surgery they need for a cure for their cancer.
Absolutely.
So you want to talk about that?
Yeah, absolutely. So, once we know what you have, so the way that I tell my patients and what I tell my patients is that first we got to know what you have. When, like Dr. Almubarak said, when we have small cell, squamous, adeno, etc., and this is not something that we bog the patients down with, but once we essentially know what we're dealing with, then comes the stage, which is the big thing in cancer, which ultimately dictates your treatment. Stage 1, stage 2, i.e. earlier stages, that's where we come in along with a multidisciplinary effort to say that potentially surgery is here to offer you a cure. That's our goal with surgery. Now, having said that, unfortunately, not everybody is a candidate for surgery. And the way that I think about it is in 2 ways. So are people or patients not candidates for surgery because from a disease standpoint, meaning that their disease is aggressive or it's too advanced, or is it because they have other medical issues that would make surgery risky for them, i.e. their lung functions are not that great, or they have other medical heart conditions, etc., that would make surgery unsafe for them. But we know from data that people that do get surgery specifically for earlier stage disease, they tend to do better. Unfortunately, here in West Virginia, even patients that are good candidates or eligible for surgery, by the time they come to us, it's a little late. And I would say that, again, that just speaks to the limited access that we have. And unfortunately, the lack of awareness just to say that, yes, I've been diagnosed with lung cancer, there mustn't be anything that anybody can do about it. So yes, absolutely, earlier stage we're here, and then for later stage, we can talk about what we discuss in tumor board.
Okay, absolutely. And before I move on to the later stages, I'll say that for patients who cannot have surgery, whether they don't have a good enough lung function to withstand surgery, or if they have, let's say, other bad medical problems, heart disease or something like that, where they're not able to do surgery, there are still other good options.
Absolutely.
So we talk about, I'm going to call it pinpoint radiation. There's medical terms for it.
I like that term.
SPRT or SABR or like all kind of other terminology. But the bottom line is our colleagues, our radiation oncologists are pretty good at that. They, if the disease is localized, they can do this pinpoint radiation where it sometimes be almost as good as surgery. Almost as good as surgery.
You'll have some surgeons fighting with you when you say that, but no, absolutely, Dr. Almubarak's absolutely spot on. So let's just say that you do have an earlier stage disease, and we're discussing that this might not be the best approach for you, just given your medical conditions. Well, is that it? Are we calling it quits on you? Absolutely no. There's other modalities, and again, it's an exciting time here in 2025 because we have this pinpoint radiation. I love that word because generally patients get very worried from radiation and they feel that their entire body is going to be zapped and what are the outcomes going to be. But now we can focus that, and there's some data to say that the results can be equivalent to surgery. However, obviously the surgery does remain the gold standard because not only are we taking out the cancer, but we're also sampling the lymph nodes to really know the stage of the disease, which ultimately dictates the treatment.
Absolutely. So the way we look at cancer, we talk about stages. You have, if the cancer is localized just in the lung, if it spreads to the localized lymph node, we call these hilar lymph nodes.
Yes.
Or if it goes to the lymph nodes in the middle, we call them the mediastinal lymph nodes. Now, once it gets to the mediastinal lymph nodes, we call that locally advanced disease, right? Before I talk about that, I'll just touch base on one more part, which is for the cancers, typically the ones where you do surgery for, and if it's spread to the local lymph nodes, the high lymph nodes, we typically offer chemotherapy after. As well as immunotherapy. And I'll touch about immunotherapy later on. This is meant to improve the odds of the cancer not coming back.
Yes,
we call that
absolutely.
adjuvant treatment, right?
Absolutely.
So you do the surgery and then you give this additional treatment to improve the odds of the cancer not coming back.
Absolutely.
Okay? But for the locally advanced stages, once it starts to get to the lymph nodes in the middle, now in that situation, there is still a chance for cure. And the treatment, it depends, I'm going to say, because there are many, many options, right?
Yes.
And this is where we as a group meet and talk and decide what's the best way to do it, right? Sometimes we start with a combination of chemotherapy and immunotherapy and then go to surgery. Sometimes we treat with definitive radiation with chemotherapy. So there are many variables. We don't go to have everything single case there, but I'm going to say that there is a chance for cure, and again involves what I call multidisciplinary clinics, basically expertise from the surgeon, from the radiation doctor, from medical oncologist, all of us working together to try and basically to cure the cancer. The treatments could be more tough, but we have fortunately very good supportive team here. I mean, it's not just us, the doctors, right? Like there's the specialty care nurses, the nurse practitioners or physician assistants. There's a whole bunch of other people that watching the patient very carefully, making sure we monitor for side effects. We make sure that the patients are getting what the care they need.
Okay, so Dr. Almubarak, so now that makes me ask you, one other question, myth or fact. Typically when we, again, you touched on all these points that the treatment depends on a lot of factors, right? So that again speaks with the individualized, personalized care that we're giving every patient. We don't treat every patient the same because every patient, like every person, has a different personality.
Yes.
Every cancer has a different personality. And we believe in treating every cancer very, very personalized. And we'll talk about the different agents in a moment. But it's very important to come together as a team to give you a individualized care, not just as a patient, but mind, body, soul. So we have all of these teams. We have amazing medical oncologists, and I'm not just saying because you're sitting over here, but because we really do. And the radiation oncology doctors, the palliative care doctors, we have everybody treating not just your cancer, but you and your family together. So myth or fact, tell me, patients, again, we talked about radiation. Let's talk about chemo. patients come in and say, I don't know if I want to get chemo, and I don't know if that's my only option. That must be for lung cancer, and that's going to be really hard on my body. How do you address that?
So, I mean, I'll take a step back. So the first thing I'm going to say is not everybody gets chemo, right?
Yes.
So we do check for what we call these molecular biomarkers, right? And even in the earlier stages, even somebody stage 1, stage 2, we check for these markers. And essentially, a lot of times the treatment might not necessarily be IV chemotherapy. Sometimes it could be a biological drug, like a pill, essentially, right? A pill that targets that specific DNA change, and hopefully, like either control it or fix it, basically. So when it comes to chemotherapy, that's also not one size fits all. There are different types of chemotherapy for different types of cancer, different histologies in lung cancer. But we also look at the person, right? Like, somebody who's 80-year-old is not the same as somebody who's 50-year-old.
Absolutely.
The doses will be different. We monitor, like we sometimes base the dose based on the kidney function, on the liver function. So we basically try to tailor the therapy that it fits that specific patient, right? So the other thing I'm going to say is more and more, we're actually using less and less of chemotherapy. If I look at the number, I have clinic today. I have a full day clinic on Wednesday. And basically, if I look at the patients I'm seeing, probably a third at this point are getting chemo. There is more and more patients getting immunotherapy, getting biological drugs. So, chemotherapy is not completely out, but it's definitely utilized way less than it used to be. The side effects we're dealing with, we're doing much better with as well, too. So we talk about the medicine we give before chemo to prevent, for example, nausea and vomiting. That we made significant advances in that. It's not the same as it was 15, 20 years ago. We basically don't take any side effect for granted. We say, hey, if there's a side effect there, hopefully we can do something to either prevent it or take care of it. So the thing that tickles me when I hear it is when a patient tells me, I see people and they can't tell if I have cancer or that I'm getting chemotherapy. That means we're doing our job well, that we're handling the side effects well, that they're going about their life and doing things and, enjoying their family and being active and all that.
Absolutely.
So going back to having precise treatment or, having treatment tailored for the patient, the biological drugs is a good example of that. Lung cancer, it certainly has probably more actionable, I call them actionable, meaning that there's a mutation or change in the DNA that we have a medicine for. There are probably other cancers. And we made a significant change in that in the last 15 years.
Absolutely.
We always order molecular testing, both at the time diagnosis, sometimes from the tissue, from the cancer itself.
Yes.
That's why we always appreciate your help with getting more tissue. But sometimes even from the blood, we can do that as well, too. And we don't do this one time. Sometimes the patient is getting treatment, their cancer gets worse. We say, hey, let's get more tissue tested again and see if there's another medicine we can give them.
Yes.
So both, again, when I look at the cancer, and then again, I'm probably more focused now in advanced stages, because at this point we're talking about the people who are not candidate for surgery, maybe they're not candidate for definite radiation. We look at these patients, as more like, hey, I need to do my best to try to keep this patient alive for as long as possible, so that they're with their family, then they're taking care of themselves. But at the same time, I need to make sure it's a good quality of life.
That's very important.
Absolutely, good quality of life. So you mentioned earlier that we have palliative care doctors in the clinic with us. I commonly involve them early on. We want to make sure the patient is having pain, that pain is addressed. If they have any other symptoms that we can help, we make sure that addressed as well too.
In fact, it's within, they've expanded the guidelines and to say that the earlier you involve palliative care docs, not only do those patients do better, but they live longer. And so I guess that's, again, very important, how it's just not a individual effort on anybody's part, but really like a completely entire village coming together to help you and your family. So Dr. Almubarak, to a layman, to a patient, they understand what chemotherapy is because they've heard it from their friend, neighbor, family. Yeah. How do you explain the concept of immunotherapy to them?
Sure. And I'll say one more thing. You're correct. A lot of people know what chemotherapy, but they like immunotherapy. Like, what is that, right?
Yes.
So I'm just going to take one step back and talk about the chemo just a little bit.
Yes.
So a lot of time for chemotherapy, we try to give it to the patient to get what we call a port, right? A port is a device that's inserted, minor same-day surgery. It's put under the skin. I tell the patient that, hey, like if we keep just sticking you with regular IVs, you'll run out of veins pretty quickly.
Yes.
So it does make it way more convenient. And there are things we can give for help with that. as far as immunotherapy is, so cancer as a disease, it's, I mean, it's, a lot of people have a lot of myths about it, but cancer, part of the reason why it happens is due to the immune system not being able to recognize and fight it, right?
Yes.
So your immune system kind of blindsided, like says, hey, these are my own cells, I'm not gonna
Yes, cancer cells are sneaky.
Yeah, they are.
Yes.
Absolutely. They're very sneaky. They're like, they trick your immune system to tolerate them, right?
Yes.
So in the last 10 years or so, we have this new class of drugs. We call them checkpoint inhibitors. What they do is they essentially take off the brakes from the immune system to fight the cancer. And essentially by doing that, they not only, sometimes they shrink the cancer, but a lot of times they prevent the cancer from coming back. They basically let the immune system do its job. Take the break from the immunotherapy, from the immune system. These drugs in general are much better tolerated than chemotherapy. They do have side effects. Sometimes the side effects could be severe, but overall, they're significantly better tolerated. And a lot of times, some patients, depending on some markers we test in their cancer, might be able just to get that alone without getting chemotherapy. So that's an option for many patients. Immunotherapy have dramatically changed how we look at lung cancer in general. 15 years ago, if I see somebody with stage 4 lung cancer, I say, hey, you have this non-curable cancer. You might live for a year, maybe at best 18 months. Nowadays, with immunotherapy, we have people who are for several years. Not everybody, and we're honest. I want to make sure I'm always honest with the patient, tell them what's going on. But many patients have advanced metastatic disease, and they're alive with lung cancer.
The 5-year survival rate has improved, and there's new stuff now on the market that we can also additionally offer besides the systemic treatments to help with that. So I think we might be running out of time for our viewers now, but I think this was a great discussion, Dr. Almubarak. We touched why are we so passionate about lung cancer? Why are we here in West Virginia? We talked about screening, what people are eligible for it, and if you're not sure, just go to the Lucas website or ask your primary care physician and see if you're eligible to get a low-dose cancer. And again, you don't have to stop smoking. We talked about diagnostics. We talked about treatment, which includes surgery and/or systemic therapy, including immunotherapy and/or radiation therapy. But it's our job to all come together to figure out what is the best plan for you. Do we have any final parting words for our viewers? Okay.
Well, I mean, thank you. I think that was a pretty good coverage for, and I appreciate, obviously, I'm going to say you do a great job in terms of making sure you cover all these points. I think the key thing is it's time to look at lung cancer different than we looked at, 15, 20 years ago, right? As a disease, I personally, and try not to, but I try to think of it almost like a chronic disease, right? Like, not for every patient, but for a lot of patients, I think it's time to move on beyond that stigma that, hey, you smoke, thus you deserve this. Absolutely. Yes. We're definitely, we don't look at it that way. Also, you have this cancer, there's nothing we can do about it. No, we think of it as like, hey, we got all these tools, right? We got, all these modalities that we can help the patients with. We're definitely in a different era when it comes to dealing with lung cancer. It's definitely a disease that's there, but we have a lot of modalities that can help the patient, that can make them have a better quality of life, that extend their life, and hopefully, for a lot of cases, I should say, we have a cure for a lot of stages of lung cancer.
Yes.
But even more and more, we're actually making steps.
We're making progress. We're making progress. It's a scary diagnosis no matter what time or who gets it around you, but it's important to remember that now more than ever, we're seeing patients not only survive, but we're seeing patients thrive after their treatment. So it's very, very important to get to us early to see if you're eligible for upfront surgery or other modalities to see what we can do best for you.
I'll add one more thing before I conclude, which is a lot of these advancements are due to clinical trials, and that's probably the last thing I want to emphasize.
Absolutely.
If I'm doing the same thing I did 15 or 20 years ago, we're never going to get better, right? So I want to thank all the patients, and a lot of immunotherapy we talk about getting approved here, and we have several clinical trials. A lot of West Virginians participated in that led to the approval of these drugs. So the patients who do this, who volunteer to say, hey, I'm going to be part of that clinical trial, and they might not get the new treatment, they might get the standard treatment, but they become part of something bigger, which is to advance the care of other patients, so the people that come after them. So I want to thank these guys. I mean, I think the reason why we do better is our patients.
Absolutely, absolutely, and their family members and everybody coming together. And clinical trials is so important because now we not only here absolutely give the standard of care, but for patients that are not responding to the traditional therapies or not candidates for one versus the other, we have other stuff that we can offer them that's not currently being offered elsewhere. And that's where clinical trials come in. And we absolutely appreciate our patients being a part of that, and you guys, coming together and doing that. So I think it's any other last parting thoughts, Dr. Almubarak?
No, thank you. And again, I look at my colleagues as I have first contact with them, whether it's a surgeon, radiation. So we look at the patient as like a family member, for lack of better words, basically.
Yes.
So we want to basically, when we discuss them and all that, we want to make sure we get them the best treatment that's out there.
Absolutely. All right. So this wraps up this episode of Cancer Close Up. Every conversation here is another step towards taking better care of you, the hardworking people of West Virginia. I'm Nida Bham. I'm one of the thoracic surgeons, and I'm here with Dr. Almubarak. Thank you, who's a medical oncologist. Thank you all for listening, and thank you for tuning in.